This program is brought to you by Emory University.
As you can see on your screen this morning, our speaker is Dr. Akanksha Agrawal. Dr. Agrawal is originally from India, is where she did her medical school. She came to the United States and did her residency training at Einstein Medical Center in Philadelphia, like a few of our other fellows did as well. She did a chief resident year as well at Einstein and is now currently a second year fellow in our clinical track, and is likely headed towards a heart failure transplant fellowship someday. So she is going to today talk us through a case from the CCU not too long ago about a case of fulminant myocarditis. Dr. Agrawal.
Thank you, Dr. Williams. So I'm going to talk about a very interesting case that I saw during my CCU month last month. This is a 19-year-old boy who had recent COVID illness in July, who went to the urgent care for 3 to 4 days of fever, chills, malaise, and testicular swelling and pain. He was treated with doxycycline as an outpatient, but did not improve, and 2 days later presented to an outside hospital with worsening shortness of breath, fever with a Tmax of about 104 degrees, chills, petechial rash, and hypotension. He was admitted with concern of septic shock. They did an echo at the outside hospital, which showed biventricular failure with EF of 25%. The LV and diastolic diameter was 4.8, which is normal. He had a right heart cath showing elevated filling pressure with a CVP of 23, a PA pressure of 43/29, and a wedge pressure of 30. He was in cardiogenic shock with a cardiac index of 1.6, and this was on dobutamine 2.5. His dobutamine dose was increased. He was started at the Leofed at the outside hospital, and he underwent a balloon pump placement for worsening cardiogenic shock. At this point, he was transferred to the Emory University Hospital to our CCU. On arrival to the CCU, patient was still substantially short of breath. He had pain on swallowing, he had fever, malaise, and features of orchitis were still present. Going over some of his other history, he's been a non-smoker and a non-alcoholic. There was no illicit drugs use. He has not been ever vaccinated as a child. His family history was not significant as well. On exam, his vitals are pretty remarkable for hypotension, tachycardia with heart rate of 120, tachypneic to 38 per minute, and saturating 95%, requiring 80% FiO2 using via the airflow. His temperature was still high, 38.8. On exam, he appeared diaphoretic, he appeared tachypneic, he was tachycardic, like we mentioned, and he had diffuse crackles on respiratory exam, mildly enlarged testicular sac on the abdominal and GU exam, and presence of mild blanching red macular lesions on the dorsal aspect of his feet that he was having for the last 2 to 3 days. His numbers, PA catheter numbers when he arrived to the CCU were better than how they were at the outside hospital with the balloon pump support and a higher dobutamine, and they were CVP of 13 with a wedge of 25. This is on dobutamine 5. These are some of his basic lab work that happened at time 0 when he came into the CCU. Remarkable for a very mild AKI with a creatinine of 1.3, leukocytosis with a white count of 16.4, mild thrombocytopenia. His albumin was 3. LFTs were unremarkable, though his INR was 2.45. His lipid panel was quite unremarkable, except a triglyceride of 234. His troponin peaked at 5.85. He had an LDH of 487, ESR and CRP, which were high as well, a BNP of 654, and an interleukin 6 level of 12.1. The normal for this is less than 2. His UDS was negative. So given all the clinical history that we had, a young boy with no significant past medical history, with kind of a viral prodrome and acute onset cardiogenic shock, with requiring mechanical support, we had a provisional diagnosis of acute fulminant myocarditis in him. During this talk, I will be going over the definition of acute fulminant myocarditis, burden of the disease, its classification, how it presents clinically, role of multiple diagnostic tests, spending some more time on endomyocardial biopsy, its treatment, and then prognosis. And we'll be discussing about our case during the presentation itself. This was a scientific statement that was released in January 2020 for the management and recognition of acute fulminant myocarditis. And I'll be using a lot of my slides. I'll be using this reference for a lot of my slides. So myocarditis is defined as inflammatory process of the myocardium that is diagnosed by established histopathological, immunological, and immunohistochemical criteria. In 2013, there was a consensus update on using immunohistochemical data as more than or equal to 14 lymphocytes per square millimeter, including less than 4 monocytes with the presence of CD3 lymphocytes to be more than 7. What is acute fulminant myocarditis? It is basically sudden and severe inflammation of the myocardium, resulting in myocyte necrosis, edema, and cardiogenic shock. There has been proposed criteria for how to diagnose fulminant myocarditis. And over the years, as you can see from 1991 to 2017, there have been slight changes. Going over the criteria, which is currently being followed and established, it's an acute illness with history of usually less than 2 to 4 weeks since the onset of symptoms. There has to be hemodynamic instability due to cardiogenic shock or an arrhythmia, including sudden death. There has to be a need of hemodynamic support, which could be inotrope and or a mechanical circulatory support. And there are multiple foci of active myocarditis, which could be regardless of the type of inflammatory infiltrate on the histological examination. So all these 4 features combine the diagnosis for fulminant myocarditis. The burden of the disease, definitely it's one of the underdiagnosed diseases because out in the periphery, patients, maybe they are with cardiogenic shock for a longer time before this is thought or this has been diagnosed as a fulminant myocarditis. Based on the ICD-9 coding, the global prevalence of myocarditis, and this is myocarditis overall, was estimated to be about 22 per 100,000 patients annually. Viral myocarditis has an incidence rate of 10 to 22 per 100,000 individuals. It has been, per the most recent scientific statement, it is the 3rd leading cause of sudden cardiac death in competitive athletes. And it is reported to be up to 12% of the young adults actually present with the sudden death. Most of the studies of acute myocarditis report greater prevalence and greater severity in male patients, speculating maybe some hormonal protectiveness from the in the women for this disease. And then overall, fulminant myocarditis is most frequently seen in young and pediatric population. There are multiple ways how we have classified, how people have classified fulminant, how people have classified myocarditis, and also then we'll talk about some of the subtypes that can cause fulminant myocarditis. Based on the biopsy, the inflammatory infiltrate that is present, myocarditis can be defined as, like you can see, lymphocytic, which is typically viral or autoimmune in nature, neutrophilic, which is typically bacterial, fungal, or early viral, eosinophilic. Most common causes of that is hypersensitivity myocarditis and hypereosinophilic syndrome, granulomatous, which is present in sarcoidosis, and giant cells, which is seen in giant cell myocarditis. On the basis of etiology, this is how the inflammatory cardiomyopathy or myocarditis has been classified. Etiology being either autoimmune, toxic, or infectious. Autoimmune, there are multiple causes listed here. However, I would just talk about a couple of them a little bit in more detail. Autoimmune includes connective tissue disease, giant cell, myocarditis, sarcoidosis, and then eosinophilic. One point to note, eosinophilic myocarditis, like in the type of inflammatory infiltrate that we will see will be eosinophilic, can be present in hypersensitivity myocarditis, which is seen with multiple drugs. And in this list, one of the drugs that my faculty mentor for this talk, Dr. Berg, also wanted me to bring to the attention of the crowd was dobutamine, which is quite frequently used as an inotrope, but should be kept in mind if a person is suddenly worsening while on dobutamine to think of hypersensitivity myocarditis from dobutamine. There have been cases seen of this. The other causes in the eosinophilic include the hypereosinophilic syndrome and endomyocardial fibrosis. The other etiology for myocarditis could be toxic, like cyclophosphamide, arsenic, cocaine, checkpoint inhibitors, which we will talk about, and bites from certain insects. And then infectious, which is one of the larger subcategory, which could be further protozoal, fungal, bacterial, viral, and parasitic. We'll talk about more of viral causes during the presentation. One point to bring about is Chagas, which not commonly seen in our part of the, in this part of the, in this area. However, if the studies are seen from the Latin American side, there is definitely mention of Chagas disease there. Some of these myocarditis subtypes result in fulminant presentations, and they have been basically divided into 4. Acute lymphocytic myocarditis, giant cell myocarditis, acute necrotizing eosinophilic myocarditis, and the immune checkpoint inhibitor myocarditis. We'll talk mainly about fulminant lymphocytic myocarditis because that is what our patient had. But I will talk about like one slide about the other ones as well at the end. How does viral myocarditis happen? So this, the pathogenesis of viral myocarditis has been divided into 3 phases. These phases are more clearly seen in the mouse models. Clinically, I would say that these phases cannot be really distinguished. However, there are certain biomarkers, viral tests, serologies, which are present or absent on the basis of how the disease is progressing through these 3 stages. So the first stage is direct virus-mediated myocardial injury. Second phase is autoimmune or immune-mediated, basically, myocarditis. And the third phase is broadly myocardial remodeling leading to dilated cardiomyopathy. This is the first phase where the virus enters the cell. It replicates within the cell, causing destruction of the cell, causing virus-mediated myocarditis. This also leads to infection of the surrounding cells, and this is how the virus spreads in the myocardium. This is when a person's innate immunity comes in and starts to act against the virus, sometimes leading to an incomplete viral clearance. And the immunity further leads to immune-mediated myocarditis by having this molecular mimicry and autoimmunity reactions. This progresses to a low grade of viral persistence in some cases. In some cases, there is complete recovery too, and there is complete, the viral clearance happens to a complete extent. But in about, seen in about 30 to 40% of the patients, they do progress to dilated cardiomyopathy after having this cardiac remodeling. So what we see clinically is actually during phase 1, when the virus is replicating a lot and when the virus is causing the myocarditis, you would see the cardiac biomarkers like troponin to be high in phase 1. In phase 2, since we continue to have myocarditis, which is immune mediated, the biomarkers are still high. And then in the third phase, once remodeling is occurring, one might not be able to see the biomarkers. The viral culture or tissue PCR is usually positive in phase 1, Depending on how effective the viral clearance is in phase 2, it might be positive or negative, and it's usually negative in phase 3. The viral serology, which is checking the antibody level of the virus, is typically not present in phase 1 because it's too early for the body to generate autoantibodies. They are eventually present in phase 2 and might be present in early part of phase 3 and then negative. On biopsy, and we'll talk about Dallas criteria in more detail when we talk about biopsy, but it is the histological criteria to diagnose myocarditis. And in early cases of phase 1, when not a lot of inflammation is there and it's mostly the virus damaging the myocarditis, there might be absence of tissue diagnosis, absence of Dallas criteria on the biopsy, which is definitely present in phase 2, and some decreased inflammatory infiltrate and variable fibrosis in phase 3. So like I said, these 3 phases might not be distinguishable within the body while we see them clinically. However, there are certain markers, like we discussed, which can point towards how the person is progressing in their illness. So how does a patient present clinically? It's a varied set of symptoms with or without systemic manifestations of an infection that was the etiology, or an inflammatory disorder that was the etiology. Most of the cases, there actually are no signs or symptoms of an infection, as has been commonly observed. Some of the symptoms are dyspnea, chest pain, new onset heart failure, cardiogenic shock, arrhythmias such as atrial fibrillation, ventricular tachycardia, or heart block. How does an EKG in a patient with myocarditis look like? There might be changes like low QRS voltage secondary to myocardial edema. Rarely LVH has been seen as well. There might be non-vascular distribution of ST segment elevation. However, that being said, I did find some case reports talking about vascular distribution of ST segment elevation and how that was one of the mimickers of ACS, however diagnosed as myocarditis. And then there might be evidence of pericarditis, such as PR depression, and frequent ectopy, ventricular arrhythmias, or conduction abnormalities. Laboratory workup in a patient with viral myocarditis. Typically, cardiac troponin is almost always elevated. But that being said, from few of the studies, it has been established that the amount of troponin elevation does not correlate with the cardiac adverse events that happen later during the course of illness. The ESR and CRP have been noted to be high as inflammatory markers. Evidence of worsening LFT secondary to shock liver, BNP or pro-BNP to be high, and this has shown to have prognostic significance. And then peripheral eosinophilia, which, like we discussed, one of the subtypes in the eosinophilic category to be hypersensitivity myocarditis, which is typically drug-related, and about 65% of the patients of them have shown to have peripheral eosinophilia. Routine viral serologies are typically not recommended, and this is from the AHA2. They are not recommended because they are typically not, like we saw in the first stage of the illness, they're not positive then. They take time, and they're more done for the academic purposes than for diagnostic reasons. Most of the time, patient already is either getting better or getting worse by the time these results are coming in. On echocardiogram, the LV size, because it's an acute process, is typically normal size or only mildly dilated. LV wall thickness can be increased because of the myocardial edema. The LV function is decreased, and there can be subsequent formation of thrombus secondary to that. There is seen cases where there is pericardial effusion along with this. And RV function, if affected or if bad, has been shown to be an independent and one of the main predictors of death or cardiac transplantation in patients with acute myocarditis. Moving over to one of the more sophisticated techniques, which is used more these days, is cardiac MRI. And that being said, when cardiac MRI is added with contrast enhancement, it has even more sensitive as a test to detect myocarditis or say any other disorder. How we see contrast enhancement in a patient with myocarditis is more in the epicardial area, which differentiates it from ischemia, which is more in the subendocardial layer. But that being said, there is always an exception to the rule. And here, eosinophilic myocarditis has striking involvement of the endocardium as well, sometimes in addition with epicardial involvement, sometimes just as an endocardium. But typically, myocarditis involves the epicardium. Sometimes people like to do an MRI to more so localize the area where they can get the biopsy from. It improves the yield of the biopsy samples. This has been, Lake-Louis criteria is one of the criteria that has been well established to diagnose someone with myocarditis on the basis of MRI. Presence of at least 2 out of these 3 features of these 3 criteria diagnose someone with myocarditis with about 79% diagnostic accuracy. The first point in the Lake-Louis criteria is edema, which is seen as T2 enhancement, which could be regional or global. Second is presence of scar or active inflammation, which is seen as late gadolinium enhancement, usually in the subepicardial area like we discussed. Although, like we said, subendocardial infarct has also been observed. And the third part is early gadolinium enhancement, which is basically an evidence of myocardial hyperemia. So going over, we talk about contrast enhancement and T2 mapping and T2 enhancement. So T2 enhancement, if present, signifies edema, and gadolinium enhancement, early and late, both are features. If any of these, two out of these 3 are present, it goes towards myocarditis. This is an image where we will discuss about case 1, how T2 weighted images are showing this hyperintense area in the inferior and the lateral wall, consistent with myocardial edema. And then on late gadolinium enhancement, there is there's contrast enhancement in the late phase, suggestive of either edema or fibrosis. When both together, this suggests myocarditis. Similarly, in case 2, however, here, in case 1, as you can see, it is kind of a transmural and more so subendocardial involvement as well. In case 2, here there is hyperintensity in the LV wall during the T2 weighted images, suggestive of myocardial edema, and then subepicardial presence of contrast enhancement in the late phase, suggestive of myocarditis. In addition to helping with the biopsy sampling, helping with the diagnosis, MRI also gives us an indirect evidence of viral pathogen. This has been seen in very small studies, so there are many much more sophisticated viral markers, viral PCR that should be done to find out the exact cause of the pathogen. But depending on how the late gadolinium enhancement is occurring, there has been a mention of how this could be this particular virus. A lateral wall LGE is usually consistent with parvovirus B19, septal with the human herpes virus 6. More extensive forms of LGE across different areas of myocardium is usually raises suspicion for giant cell myocarditis, and a diffuse but also subendocardial involvement, like we mentioned, raises concern for eosinophilic myocarditis. Moving on to one of the major tests that we do here is the gold standard for the diagnosis of myocarditis, and it is the endomyocardial biopsy. Along with the histological Dallas criteria, which we go over in the next few minutes, and with the new tools of immunohistochemistry and viral PCR, there has been much improved sensitivity and specificity of this test in diagnosing myocarditis. So what is an adequate sample? Presence of 4 to 5 interpretable endomyocardial tissue fragments of about 1 to 2 cubic millimeter in size, with more than 50% of each fragment consisting of myocardium, is considered to be adequate. A borderline sample is usually 3 of those samples, and an inadequate sample is usually either 2 or below 2, with less than 50% of the myocardium that is interpretable. So as per the ACC-AHA recommendation, a person with unexplained acute cardiomyopathy, if they have any of one of these features, which includes if they're requiring inotropic or mechanical circulatory support, which by definition, they already fall in the acute fulminant myocarditis category if they have that. If they have Mumps type 2, second degree or a higher heart block, if they have sustained or symptomatic ventricular tachycardia, or a failure to respond to guideline-based medical management within the first 1 or 2 weeks, any of those patients, if they meet any of these criteria, should get an endomyocardial biopsy as a class 1A1 recommendation. If they do not have all those features, but they have an unexplained acute cardiomyopathy, it's class 2B for them to get cardiac MRI. Since this might be the best time to go over some of the cardiac biopsy indications, which have been, this is from the 2007 task force and the AHA ACC scientific statement, which tells us as to all the scenarios when one should get a biopsy. I have just put in all those scenarios mentioned in that task force table and mentioning there how they are trying to diagnose acute fulminant myocarditis or acute myocarditis and differentiating it from the other causes of myocarditis. So those are all the scenarios in which a patient should be getting an endomyocardial biopsy. First is, as we went over, it's less than 2-week duration of new onset heart failure, which is associated with normal sized or dilated LV and hemodynamic compromise. And such a patient, one is suspecting fulminant myocarditis, and they get the cardiac biopsy, and they should be getting cardiac biopsy as a class 1 recommendation. If one has new onset heart failure, but they are within 2 week to 3 months duration and associated with a new arrhythmia, second or third degree heart block, or a failure to respond, in that situation, also as a class 1 recommendation, one should be getting a biopsy. And here one is looking for fulminant myocarditis, giant cell myocarditis, which might have been undiagnosed or presents late, and sarcoidosis. If the heart failure persists for more than 3 months and all the above features are still present, it's a class 2A recommendation still to do a biopsy. Here one is wondering if the patient has sarcoidosis. Then patients who have dilated cardiomyopathy and have been associated to have a suspected allergic reaction or eosinophilia, you're suspecting them to, you're checking for eosinophilic myocarditis and hypersensitivity, and it's a class 2A recommendation to do it then. Some of the other indications are anthracycline-induced cardiomyopathy. Out of our talk here, but just for the completion's sake, they've been mentioned in this table. Heart failure with unexplained restrictive cardiomyopathy, also a class 2A recommendation. And these are the other recommendations where, again, the 2 and 3 points in the previous slide, which was 2 weeks to 3 months and more than 3 months, if they do not have one of those arrhythmias, they get a 2B class recommendation to test for the biopsy. Just mentioning here that unexplained atrial fibrillation is class 3, where no biopsy should be done. The rest of the 13 scenarios are for one to get a biopsy. So how do we diagnose myocarditis on a biopsy? There's a well-established and taken Dallas criteria, which was published in 1987. And according to that, depending on how the infiltrate and how many cells one sees, one can classify the sample as active acute myocarditis, borderline myocarditis, or no myocarditis. So if the lymphocyte infiltrate is more than 14 cells per square millimeter with evidence of myocyte damage, they have been classified as active myocarditis. If it's a milder infiltrate, it's borderline. If there's no infiltrate, it's no myocarditis. That being said, histology by itself is highly specific, but only 10 to 35% sensitivity for lymphocytic myocarditis. And in one of the papers, actually, if one has to increase the sensitivity to 80%, one needs to do about 17 right ventricular biopsy samples. But with the immunohistochemical markers and the viral PCRs, like I mentioned before, the sensitivity and specificity of the biopsy has improved dramatically. These are some of the common immunohistochemical markers, which we would not delve into, not of much importance to a cardiologist. But that being said, just CD3 marker is for T cells, CD20 is for B cells, and this is what they test to see what kind of cell is present in the inflammatory infiltrate. The topic of biopsy is incomplete without talking about risk of performing an endomyocardial biopsy. The overall complication rate that has been written in the literature varies from less than 1% to 6%, even in the best hands. The less than 1% data comes from a survey sample of more than 4,000 biopsies that was done on patients who underwent transplant or on cardiomyopathy patient. The 6% complication data comes from the study Deckers et al., which was a prospective observation on 546 patients over 7 years. And what they found was a combination of all these complications, some related to sheath insertion, about half of them, and about half of them related to the biopsy procedure itself. The sheath insertion included arterial puncture during local anesthesia, vasovagal reaction, or prolonged to venous oozing after the sheath removal. The biopsy procedures include, as we can rightly imagine, arrhythmias, conduction abnormalities, possible perforation or definite perforation, and rarely patients died too. So it's a test which comes with its risk, but definitely has a huge role to play in diagnosis of acute myocarditis, especially acute fulminant myocarditis, because patients with acute fulminant myocarditis, since they have either mechanical support or they're too sick, they cannot get cardiac MRI in their workup. So the role of endomyocardial biopsy is even more important in those cases.
So if I could just interject one quick thing there. The important thing about that Deckers paper is that they did not include any of their transplant patients in that study. So there's a huge difference in the risk, the serious risk with a transplant versus non-transplant patient. So that's why that study is applicable to our patient.
Correct, yes. Thanks, Dr. Burke. Going back to our patient, so our patient got all those studies that we have talked about so far, not the cardiac MRI because he had a balloon pump. His EKG showed sinus tachycardia with no major, pretty unremarkable EKG otherwise. His tele remained normal without any evidence of arrhythmia during the hospital course. His echocardiogram showed, that's the parasternal long axis view, and that is the short axis view, showing decreased LV and RV function both. Pretty remarkable, and this was called to be about like 20% or 15 to 20%. This is the echo. Our patient within few hours of admission into the CCU got an endomyocardial biopsy, which was echo guided. This is the cardiac biotome, which is currently getting a sample from the right-sided interventricular septum. Next, our patient, the biopsy that we got, we sent it for pathology, and this is on the left side is how a normal myocardium appears like. There is the striated muscle fibers and the blood vessels is how it appears. Just from the end of the room, if we can see the right side, which is from our patient actually, and the right side seems to have more purple dots. That's how I saw it, and which goes along with higher inflammatory infiltrate. It was read as presence of interstitial inflammation comprising of CD3 positive lymphocytes. Some PMNs and some eosinophils were also present. There was also focal myocyte injury, which was characterized by myocyte attenuation and hypereosinophilia and loss of cross striations and feathered cytoplasm. Overall, our biopsy did meet the Dallas criteria for the diagnosis of myocarditis. And then we did test viral markers on our patient. These are, so going back, we knew our patient had COVID illness, so his IgG was positive. However, his PCR for COVID was negative. His adenovirus negative, Coxsackie virus negative, echovirus negative, EBV negative. We also checked for Rocky Mountain and ehrlichiosis, and both were negative. That being said, though we did an extensive viral workup, the viral serology usually does not, per the HA recommendations, usually does not have a huge role to play in the management of patients with acute fulminant myocarditis, because one, it takes time to come back, and second, the patient, because it does take time, the patient is either already better or worse. One thing to note in this is that Mumps antibody IgG was negative in our patient, which goes along with him being not vaccinated. To the crowd who joined a little late, this is our 19-year-old boy who comes in with symptoms of fever, chills, orchitis, some difficulty in swallowing, and has never been vaccinated as a child and is diagnosed with acute fulminant myocarditis. His IgG was negative. His IgM for mumps came back equivocally positive at a value of 0.95, where the reference limit is 0.79, less than 0.79. We did a buccal swab on him for mumps PCR, which was negative, and his PCR for mumps on the cardiac biopsy is still pending. This is being done at the CDC lab. So overall, given this picture of clinical presentation of a viral prodrome in a patient who has orchitis, who has some evidence of parotitis, with absence of vaccination as a child, and presentation as acute fulminant myocarditis. One of our working etiologies on this patient as to why he has acute fulminant myocarditis is actually mumps. Is mumps myocarditis a forgotten disease? Might be. It was first reported in 1918. In 1945, people found out that it has it can lead to EKG abnormalities, and complete heart block was first described in a patient in 1945. By 1950, the cardiac involvement reached about 15%, which then dramatically reduced down because of the vaccination becoming more available. It has been typically seen that mumps myocarditis occurs on between the 5th and the 10th day after onset of mumps. And the mechanism of death in mumps myocarditis is believed to be arrhythmias or cardiac dysfunction. To note how serology plays a role in diagnosis of mumps, IgM typically starts rising during the early phase of the infection, peaking at between about like 7 to 14 days, I would say more so 10 to 14 days, and then dropping down. The IgG picks up after about a week and then usually persists through life. The serologies were done at about this time in our patient at about day 7. So we caught a negative IgG, which means that he was never infected before or never vaccinated, but our IgM was low positive, let's say, because or low positive maybe because we had not yet reached the peak of IgM. To diagnose mumps, one needs either IgM antibodies, which are positive, though false positive and false negative are seen. The second, one can look for IgG seroconversion, which we will be checking for. We are hoping to get a sample on our patient in about 6 to 8 weeks from his index presentation and see if there is a 4-fold rise in IgG, which would also confirm the diagnosis. And then the next step is checking RT-PCR or cultures of the mumps, which can be done on the tissue. A positive confirms the diagnosis, the negative is still inconclusive. And there are certain features on CBC like leukopenia and serum amylase level being elevated that confirm the inflammatory process that are seen in mumps infection. Going over the treatment of myocarditis or fulminant myocarditis, One important role here is of mechanical circulatory support, and to transfer a patient to a place which has mechanical circulatory support. It's usually present in a tertiary care center. Though there's no randomized controlled trial about how temporary MCS can save the life of a patient, although there are several case series that have seen that there is recovery once the circulation has been restored and the organs are perfused. And even in the absence of recovery, short-term stability while awaiting for a more definite treatment like transplantation, the mechanical circulatory support is very important in those scenarios as well. And I would appreciate how our patient was transferred from this outside hospital to EUH, within a few hours of him getting the balloon pump placed for him to get further advanced care at EUHCCU. So this is a slide which is a repetition of the previous slides that I showed. These are the major myocarditis subtypes which result in a fulminant presentation. I will be talking about the treatment of all of them, though more focusing again on fulminant lymphocytic myocarditis because that is what the patient had. Lymphocytic myocarditis, like we've discussed, viral infection is one of the more common causes, and it has been seen to be positive in about 30 to 40% of the cases. And a lot of these patients actually undergo spontaneous recovery of their LV function if they're well supported with mechanical circulatory support in the initial part. There has been multiple studies to test for specific therapies. Going over them, we'll use these tables in the next couple of slides to go over some of the specific therapies that have been tried. Prednisone has been tried in these are the randomized controlled trials that have been done for myocarditis and shown to have some benefit on inflammation on the biopsy, but no clinically relevant benefit just by prednisone alone. The last two of these is the prednisone plus azathioprine, which has shown to change the LVEF to be better. The study in the middle is the study which combined prednisone along with either azathioprine or cyclosporin A, and this is the myocarditis treatment trial that was done. And this studied about 111 patients with a histological diagnosis of myocarditis and an LVEF of less than 45%. And they compared patients receiving either the conventional therapy or this 24-week regimen of prednisone with these immunosuppressive agents. And their primary outcome was to check for a change in EF at 28 weeks. And what they found was the LVEF at 28 weeks did not differ significantly, with a gain of 10% in the immunosuppressive group versus 7% in the other conventional therapy group. Also, no significant difference was seen between the survival of the patients. The mortality rate for the entire group was about 20% at 1 year and 56% at 4.3 years. So overall, they did see some benefit in the LV function. However, it was not statistically significant. There have been some more studies that have tried IVIG with immunoabsorption. The IVIG with immunoabsorption did show a positive outcome. Some of the interferon study has shown some positive outcome. However, one thing to note is that most of these studies of immunomodulation have included patients with more chronic form of disease as opposed to the fulminant variety that our patient had. There are some ongoing trials for the following medications as well, like prednisone with azathioprine, IVIG, and anakinra. There has been a meta-analysis combining all these immunotherapies showing no overall benefit on the LV function. And obviously, there's also a study looking at statin in these patients, and that showed a very small study showing some improvement in the LVEF and the NYHA class of the patients. So overall, the 2016 AHA scientific statement on the current diagnostic and treatment strategies does not generally recommend empirical upfront immunomodulatory agents before diagnosis of myocarditis. Going over the other three subtypes of myocarditis that we know that can cause fulminant presentation. Definitely not seen in our patient, but going over just one slide about each. Giant cell myocarditis, as the name suggests, has giant cells in the pathology. It is an uncommon, frequently fatal form of fulminant myocarditis seen in young and middle-aged adults. 25% of them have a history of autoimmune disorder. Path criteria, like we said, there will be presence of giant cells. They do respond to corticosteroids plus immunosuppressive therapy pretty well. And after transplantation, GCM has seemed to recur in about 20 to 25% of allografts. Acute necrotizing eosinophilic myocarditis is usually, again, one of the rarer forms of eosinophilic myocarditis. One additional finding that is seen in this type of myocarditis is ventricular thrombosis and arterial emboli. It is the most common cause for this is drug hypersensitivity, and a close temporal relation has been seen between a drug reaction, a drug skin reaction that has been seen with this hypersensitivity reaction. This typically has a more indolent course and does not have as much arrhythmia, and on the biopsy one would see eosinophils and necrotizing angiitis. This form also responds pretty well to high-dose corticosteroids, and sometimes a second immunosuppressive agent is also used. And then, not to forget talking 1 minute about immune checkpoint inhibitor myocarditis, which is a more recent form of myocarditis, having been observed more so in the last couple of years with the use of the checkpoint inhibitors that are being used as oncological agents. Its incidence has been seen to be between 0.3% to less than to more than 1% when these immune checkpoint inhibitors are combined. It's more so a class effect and not specific to one therapy. And when used in combination, there is an increased risk of events. People typically see concomitant myositis along with myocarditis in such scenarios. And the treatment, first thing is to discontinue the agent itself. And it's been seen that in scenarios when patients have a life-threatening or a severe event and the ICI or the checkpoint inhibitor is reintroduced, it leads to an increased risk of recurrence for this disease. There is also early use of IV corticosteroids, which typically help these patients. And if they do not, then anti-thymocyte and IVIG are used or can be considered. Again, these data is still, the data for this is still developing as we are seeing more cases of it. So these are very small studies saying use of anti-thymocyte or IVIG. Overall, what is the prognosis of acute fulminant myocarditis? Patients actually with acute fulminant myocarditis do great. They at presentation have shown to have excellent long-term prognosis and are more likely to experience complete recovery than patients with acute myocarditis if they survive the acute phase, which is supported by aggressive pharmacological and or mechanical support. And the reason for this postulated is that these patients with fulminant myocarditis develop a robust immunological and anti-inflammatory response, which actually works in favor of them at the end of the day by helping the viral or viral clearance and giving them a good long-term prognosis. There are about 30% of cases which are biopsy-proven myocarditis, and again, this study does not differentiate that if they were fulminant really. So this is active myocarditis, basically. 30% of these patients progress to dilated cardiomyopathy and are associated with worse prognosis. Prognosis of lymphocytic myocarditis is generally better than its other histological counterparts like giant cell myocarditis. This is an important point since we talked about the risk of sudden cardiac death and how in competitive athletes, this is the third leading cause for death. Myocarditis is a third leading cause. A patient who recovers from fulminant myocarditis should abstain from competitive sports for at least 3 to 6 months because of the risk of ventricular arrhythmia. And this is a part of the scientific statement too, which recommends them to get a normal exercise stress, normal echocardiogram, and a Holter monitor before they can resume competitive sports. Going back to our patient, he was treated with pulse dose steroids for 3 days. He was started on broad spectrum antibiotic to begin with. He was given vanc, meropenem, and doxycycline. The vanc and meropenem was stopped day 2, and doxy was stopped day 4. This is when most of his, when our suspicion for all those agents, which we also tested for in the biological and like Rocky Mountain spotted fever, all those came back negative. Day 5, we started weaning his balloon pump. Day 6, his balloon pump was removed. Day 7, we started decreasing his dobutamine. Day 8, we got a echocardiogram, which showed improved LV function and normal RV function. Day 8, his dobutamine was turned off. He was transferred to the floor. And day 10, he was discharged home on low-dose Coreg, Eosinophilic, and a steroid taper. And this is his echo from day 8. When this was done on 2.5 of dobutamine, and as you can see, there is significant improvement in his LV function now, maybe about like around 50% of LV. Going quickly over the key points that we talked about in the last about an hour. Acute fulminant myocarditis is defined as sudden severe inflammation of the myocardium, resulting in myocyte necrosis, edema, and cardiogenic shock. Rapid diagnosis of this condition is crucial for full circulatory support to be implemented by an expert team to prevent multi-organ systemic failure. Endomyocardial biopsy remains the gold standard, though there are limitations like sampling error, low sensitivity, but like we discussed with the use of PCR and immunohistochemistry, the sensitivity can be much increased. And then overall, fulminant myocarditis carries excellent prognosis if the patient survives the initial phase, which is the second point, which is basically rapid diagnosis and initiation of full circulatory support to be a crucial part in the management of the patient. Thank you, everyone. And I would also like to thank Dr. Burke for his expert guidance during this presentation.
Thank you, Akanksha. Very good. Just another ho-hum case of mumps myocarditis. But no, very interesting case in all seriousness, and it seems like a good result. I don't have actually any questions at this point in time. Dr. Burke, I know you were involved in this case. You have any additional, if you're still on the line, any additional comments you want to make about this case?
Yeah, sure. Not too many. I think she did a wonderful job summarizing this here. I will also give her all the credit for the diagnosis. I was interviewing this guy's mother at 3 a.m. at the bedside when he came in, and she was telling me about the orchitis, and I was like, gosh, orchitis, what did he have, mumps? And it literally never entered my thought process that he would have not been vaccinated, and that would have been the cause of the myocarditis. So Akanksha actually got back with the mother and figured that important point out. I think in general for the fellows, the one thing I would highlight just based on my experience elsewhere is the biopsy stuff, which is why I wanted her to kind of emphasize some of this stuff. You guys get a very, in my opinion, unique view of biopsies here. I've been shocked since coming here at how good we are at doing biopsies. When I was at Northwestern, we would always do these biopsies in these cases if needed. This was when I was a general fellow, and but it was a big deal. They'd have a pericardiocentesis tray in the room. There was usually a second attending hovering in the control room, and they would definitely not let a junior fellow do anything other than get access. And then at the Brigham was even more extreme. We had, when I was a heart failure fellow, the cath lab ran their numbers on non-transplant biopsy complication rate, and it was about 10% for serious complication rates. So they basically put a moratorium on doing any biopsies in cases like this. And both those centers did cath, not echo based. approaches for biopsies. So I've been surprised at just how smoothly biopsies have gone here. It's a very unique perspective, but I think when a lot of you disperse elsewhere, you're going to get a lot more resistance to doing native heart biopsies from your cath labs. So that's one point that I wanted to bring up. So if nobody else has any other questions, I'll throw a curveball here to Akanksha, since she's done such a wonderful job with this. It's something we didn't discuss. What do you think about viral infection in idiopathic chronic DCM? I think you're muted.
In a patient who already has DCM and then a viral infection on top of that, is that what you're asking for?
So not myocarditis on top, just DCM in general, right? Because viral infection is considered to be one of the causes of DCM.
Right. I would say I didn't go through any literature specifically in like chronic DCM patients if they have viral infection, but I would assume in general, like immunity being low and them to have a more severe form.
Yeah, it's kind of tricky. It's a lot more straightforward in myocarditis because we have good evidence of viral infection in so many of these patients. The thing about chronic DCM, this has been just an area of fascination of mine over the years. The data on it are pretty bad, even though it seems like back in the 90s, everybody with idiopathic DCM was told that they had a viral infection that caused their heart failure. The data are suggestive that it certainly is causative, but it's not a slam dunk. So if you look, there was a study that came out a number of years ago in Circulation where they looked at an unselected case series of hundreds of patients with idiopathic DCM. And something like 2/3 of those cases actually had detection of viral genomes in the heart. And at least based on the genetics data that have come out in the last decade, you wouldn't suspect that 70% of idiopathic DCM is just due to virus, because probably 40 to 50% at the least is due to genetics. But the other thing that's come out that's interesting is there's a couple of studies that include control heart samples, whether they be autopsy samples or actual biopsy samples. I don't remember, but somewhere around 10% of controls. So control being someone that has never, ever had a heart problem, no heart failure, normal echo, normal heart function. Up to 10% of the controls actually have detectable viral genomes for the types of viruses that we know can infect the heart. So like Coxsackie, adeno, parvovirus, B19 being the most common. So the data are not, are mixed. I would say that for chronic DCM, there's probably a component of viral infection, but we really don't know which ones cause it, what the threshold is for causing it, how it causes it, whether there's an interaction with like a genetic predisposition. So it's just,
right.
Since we're talking about viruses infecting the heart, I thought I'd bring that up too.
Right. And I did go through how a viral infection in one person can lead to myocarditis, but another person would not cause the same viral infection, would not touch the myocardium at all. And that and how they postulated was a combination of genetic and environmental risk factors as well.
Yeah. What we think we know about viruses in the heart, we really don't.
This is Andy. Just a quick comment. Great talk. And I think the comments around that the ventricle was not dilated. And, we get a lot of focus on ejection fraction, but people need to recognize when you have a non-dilated ventricle in an acute setting with low contractility, that those patients are particularly going to be prone to hypotension with vasodilator therapy. If you think about your pressure volume loops and what you're doing to stroke volume, when you just lower the pressure in that situation, you don't necessarily increase your stroke volume. So that's one of the reasons these patients really need to be at a center where they can get mechanical circulatory support. This patient got by with a balloon pump, but may have needed an Impella if there's if there's someone with giant cell myocarditis, which we probably see a case every 3 years or so. They often need something like ECMO or early LVAD. So, but fabulous talk.
Thank you.
The preceding program is copyrighted by Emory University.